Welcome, everybody. We've got a guest speaker this morning. Claire Clark from GS1 will talk to us about the activities GS1 are involved with, most notably barcoding, but I guess there are other forms of digital activity which we'll hear about, which are, of course, relevant for the prevention of medication errors. So without further ado, I'd like to pass over to Claire and she will explain more. Now, the purpose of this presentation is first to educate and inform us, but also we'll be looking for suggestions about how we might follow up with GS1 to discuss further collaboration and cooperation. So any comments after the presentation, both questions on it, would be welcome. We may not have time to give you answers, and I'm sure Claire would be very happy to give some responses in writing, particularly on more technical issues. But we're also looking for any volunteers to follow up with GS1. So with that in mind, over to you, Claire, please. Thank you.
Thank you, Brian, and thank you for the invitation to come and talk to your group today. And hello, everybody. As Brian said, I'm Claire Clark, Director of Healthcare Engagement. A little bit about me before I go into the presentation. My background is I am an emergency room nurse and I still do that role now at the weekends when time allows. I left my full-time role as a nurse years ago and joined an international pharmaceutical organisation and worked in the medical team and then latterly into the commercial team. I since then have worked for GS1 UK, which is a member organisation of GS1 Global, and beginning of this year joined GS1 Global as the Director of Healthcare Engagement. My time at GS1 UK saw me lead the Scan for Safety programme in the UK. And more recently, they have moved into Scotland and Wales. So I have got some experience of implementing some of these systems as well. So, like I said, thank you for inviting me today. I'm going to start at the basics. I've assumed that we know very little about GS1, so if you're an expert, please forgive me, but there may be some colleagues in the audience that might not know just as much. So who is GS1? It's a global not-for-profit standards organisation. We're driven by our users and we facilitate collaboration amongst trading partners and our aim, I guess, is to create more efficient, safer, sustainable value chains through global standards. Where I hear you ask, where are we? I'm just trying to move this bar out of the way. That's better. Where are we? So we have approximately 2 million companies across the world. Being a member of GS1, we are in 150 countries, 25 industries, and approximately, I think this is an old number, I have to say, I need to update this number, approximately 6 billion barcodes are scanned every day. As I mentioned, GS1 UK, there are 115 member organisations that work in collaboration with GS1 Global. I mentioned 25 industries. I obviously work in the healthcare industry sector, but as you are well aware, barcodes and this technology has been around for long years in retail and grocery. So GS1 Healthcare, who are we? What you can see here is you can see an expanding committed community of global engaged stakeholders. This is the global membership. We have got many more companies working with GS1 locally, and so they're not all represented here. So you can see some larger and smaller organisations. We also have leading hospitals that are members of GS1 that help shape the implementation of our standards, and I'm sure you can see many familiar to yourself there. And I will be talking about a couple of 2 or 3 of these later on in my slides around implementation of barcode scanning. We also work in collaboration with all the other healthcare standards in the format of the Joint Initiative Council. This works with HL7, IHE, ISO, SNOMED, World Bank, all those organisations that come together and have a common interest in making the standards work in the healthcare system. So you may be sat there thinking, why do we need it? On the screen in front of you, you have a slide that demonstrates the need for globally unique numbers. These are 3 manufacturers, and I'm not calling these 3 manufacturers out because this could be interchanged with any manufacturer. And this is their catalogue number. And as you can see, they are the same catalogue numbers. However, if you were ordering an IV catheter system and you got a porcine heart valve, I think you'd be quite surprised. This is a common error that happens daily in a lot of ordering and stock systems across the world. Manufacturers absolutely have their own catalogues, but using those catalogue numbers is encouraging the error to happen. And the difference between a heart valve and an IV catheter system it is a lot of zeros. So you wouldn't want to be ordering maybe 100 heart valves, or you've got a perception you're ordering 100 catheter systems and you get 100 heart valves. I think your finance director in the hospital may be a little bit distraught with that invoice. So is it really a problem? Is this getting confused? And the counterfeit that we see? Obviously, we see increasing healthcare costs, as I've mentioned. Can you tell from those medicines which is fake? I didn't realise the issue with counterfeit when I worked full-time as a nurse. I don't think I ever would have considered that the medicines I had in my hand were counterfeit. And this is an increasing concern around the world. I'm sure you've all seen this. Probably sat in a staff room crying with a cup of coffee. Overworked workforce, especially in the last 18 months, not really knowing where to turn, can't find equipment, haven't got the stock. It's a general challenge. And then what comes in is the recall. So when there is a problem with a medicine or a product, the recall and the workforce and the time it takes to get these patients identified that are affected. I would suggest in the UK and globally, there are still about 30,000 ladies that are affected as to whether they have or have not got their PIP implants implanted in them. And that's something that in 2021, I don't think we should have in the healthcare system. So what do global standards help address? They help address medication errors that result in additional treatments, disabilities, and even loss of life. They can help in the counterfeiting, and this is becoming an increasing global threat. They have their place in traceability from manufacturer to patient, and this is currently, I think there is some really good traceability, but there are gaps in the traceability journey to the patient, and those gaps are what we need to close. Product recalls can be difficult. Often they are handwritten on paper, and notes have to be scrolled through to find out whether they are an affected patient or not. And this takes time of trained staff. And the manual interventions required in the healthcare provision are decreasing its efficiency and accuracy. So we sit here and say, okay, so if healthcare achieved 99.9%, I think we'd all probably nod our head and say that's okay. In healthcare, if we look at some of the equivalents, if we were achieving 99.9% in healthcare, which I don't believe we are, that would mean for the airline industry, a major plane crash every 3 days. In a maternity unit, it would be that 12 babies are given to the wrong parents every day. And this is astounding. The 37,000 cash point ATM errors every hour. That's their industry if they achieved 99.9%. And I'm sure all of us on the call today wouldn't agree that they are acceptable numbers by any stretch of the imagination, but yet in healthcare, we seem to have them embedded. So moving on to medicines, scanning medicines. So what do we need? What's needed for medicines identification? Obviously, there's legal and regulatory identification requirements for data capture and traceability, and that often dictates the placement of where the barcode will be. So as you obviously well aware, the barcodes on medicines, on blister packs have to be exceptionally small, as do the direct part marking of instruments. The benefit of the smaller data matrix, GS1 Data Matrix, which is what you can see on the left-hand side of the screen, is that you can get large amounts of data on a small space, whereas the 1D barcode, which is what you see on your Coca-Cola bottle as you're going through the point of sale, that's a 1D, the black and white stripes, that really holds a number only. That brings me onto it nicely. What you have in front of you here is a GS1 Data Matrix, so you can see that the GTIN serial number, lot and expiry date can all be held in that small square. The GS128, they tend to be used in packaging for pallet size, so they can be very long barcodes. And then you've obviously got the other format, which is an RFID tag. They can all hold similar information and have very similar uses, but they have their own particular use case. So if you want to find stock at a particular location remotely, sometimes RFID can be used. And I guess that's what we have to look for. But I would suggest that in medicines, the data matrix is the advocated state. So what you have within a data matrix, I mentioned the GTIN, which is the 01 number. The 01 is an application identifier. What that does in simple terms is the 01 tells the scanner that's reading it, or the human eye, that actually the number that comes after 01 is the GTIN number, the global trade item number. That's the product number. The 17 is the expiry date. The 10 is the, now I always get these two wrong, is the batch, and 21 is the serial number. So what that can do is if we put a scanner up to that, the scanner technology knows that when it sees a 01, that means that the product number is coming next. When it sees 17, it means that this is the expiry date. And this is helpful when these items are scanned at point of care. As I mentioned earlier, the difference between a data matrix, this can be a very small pack of medicines. This tends to be a larger palette of product. But as you can see, all these numbers, the AIs, application identifiers, are embedded in the data matrix, whereas they are human readable on the GS1 128. So the difference, a 1D and a 2D. Obviously, the obvious difference is that one has parallel lines and spaces, and the other one is almost dots and dashes of dark and light spaces on a grid. The main difference between the two is the 2D can hold more information than the 1D, and the 1D barcodes are scanned by traditional laser scanners, so the ones that have the red light, whereas 2D often can be read by cameras on phones, etc. The thing is, if a scanner can read a 2D data matrix, it can read a 1D, but it can't often do the same in reverse. So if you've got a scanner that historically has scanned 1D, it will struggle to read a 2D data matrix. Whereas if you have a 2D data matrix scanner, it will read a 1D. So it is often compatible. Ooh. Benefits of 2D, and I've obviously talked about these. The supplier systems are generating the data so they can encode it into a smaller area. Printing equipment is often better positioned to meet the printing requirements for 2D versus 1D. More and more healthcare providers are investing in optical scanners, so they're able to scan it, and 2D scanning tends to be faster than 1D, and that's because it's capturing 4 elements of the data, if not more, versus just the one product number. However, what we need is a harmonized approach across the world. So here is an example box of medicines. I can't tell you where it's from, but you can see the application identifiers, a data matrix, and the human readable information on there. So identification of pharmaceuticals across the world, you can see from the green on this map, these are the countries that have accepted GS1 standards. The orange is where country requires their local national identifier as well. And the skin coloured, peach coloured is currently there is no input into the identification of pharmaceuticals. So I think we can comfortable sit here and say that around the world, it's accepted that GS1 standards are used on pharmaceuticals. And I've been talking about 1D and 2D, and if we have some pharmacists on the call, I'm sure we have, I'm sure you're sat there saying, well, not every box has got a 2D, Claire, or not every box has got a 1D. So how do we use this? So this is just a snapshot of the growing number of coding and serialization requirements by country for legislation. So I'm not going to go through them all, but I will share the slides with you so you have them. And you can see the difference in the requirements, whether it's coding, serialization, packaging, batch variable. There's an awful lot in there. So and it continues to grow. I think that's the thing for me is it doesn't seem to be slowing, it seems to be accelerating. Then what we see is the green map that I showed you was around acceptance of GS1 standards to identify pharmaceuticals. And this is the countries that now are developing requirements or require a data matrix on their pharmaceuticals. So yes, it's not as broad, but it's a definitely growing market that seem to be identifying their pharmaceuticals with 2D data matrix. This has also been supported by various industry associations. So you can see on here the European Federation Pharmaceutical Industries and Associations, IFPMA and Pharma have all believe that serialization initiatives should conform to the internationally recognized standards. For example, GS1 2D barcode. Using GS1 standards allows manufacturers to deploy a single set of standards across their operations and with their supply chain partners to identify and serialize products. I think if you were in a manufacturing organization that had to deal with these varied requirements, I'd just ask if someone could just say, let's do it all the same, because I think this must be one of the biggest headaches for a pharmaceutical manufacturers to actually abide by all the legislation, etc., and serialization requirements around the world. What I have here is something that a UK hospital presented, again, quite small. Down here, you have the standards keys, all the standards that GS1 do. And across here is an example of electronic prescribing and meds administration. So when I say meds administration, in this particular hospital, it was barcoded administration. And before I go into the details of it, the two blue rivers here, patient journey, and at the bottom, what you see here is I've got fire standards, I've got SNOMED CT. DMND is the master data in the UK for the drugs and medical device dictionary. That could be interchanged, I guess, with any in-country master data that you hold for pharmaceuticals. And I guess what it shows here are the standards that potentially are used when ordering a medicine, when you get receipt of a medicine, when you are e-prescribing a medicine. And at the top here is the regulation reporting and insight that you can get from that data that you capture by the scanner. So you can get, you know, from e-prescribing, patient level costing. Oh, apologies. You can get which patients have had which medicines, so from a product safety recall. You can also look at adverse event reporting, so you could use this data for post-marketing surveillance, incident reporting. And I don't believe that the UK have captured everything here. I think this is just an example of where and how the standards could be used across the patient pathway. And I guess the arrows or the little bridges, which I do believe these are meant to be at the bottom, is how the data, when it's scanned, can be held in the pharmacy robot, could be held in the pharmacy stock system and updated, in the dispensing system, again, and updated, once given into the patient record, and obviously, in essence, closing that loop of closed loop meds administration. So I'm happy to answer any questions, should you have any on those at the end. What I wanted to talk about is just, I've got 3 here that I may not do 3, I may just do the 2, is the Royal Cornwall Hospital. So the chief pharmacist at the Royal Cornwall implemented, he did a study around scanning in dispensing. And as you can see on the graph here, in the 3rd column, dispensing error rate in period 1, this is when there was no barcode scanning. And you can see the incidents or the type of incidents that happened. When introducing barcode scanning, for exactly similar sort of period with the same staff, you can see that actually the barcode scanning dispensing prevented a 78% prevented error rate, which obviously the team were, I think, surprised at. Interestingly, when the chief pharmacist asked the team that did this study if they would want to continue barcode scanning, only 89% said yes. Now, I think that highlights what I will come on to is the challenges. So don't underestimate the change management required here, because I don't believe anybody gets up to do harm or make an error. But actually, when you look at some of those questions and seeing that you didn't get 100% to say, yes, we would carry on scanning, it's understanding what that means. Antonius Hospital in the Netherlands, they've got an awful lot of slides, and I've just snapshotted because they've got some numbers here. I'm happy to go into further detail with anybody that wants to understand these scenarios more, but actually a 51% reduction with barcode scanning. And there are some smaller numbers here, but are all quite large numbers. So in Antonius, they got a 67% reduction of barcode scanning at dispensing. So definitely something that can help your patient safety never events. And then St. Jandal's Hospital, again in the Netherlands, you can see that they prevented 654 medication administration errors in a roughly 51,000 administrations during the first month of going live. I think one thing that has been highlighted to me in a lot of these projects or implementations is patient ID. And interestingly, this hospital achieved 95% of confirmed patient identification compared to other hospitals using the same EMR and barcode meds administration, which I think is quite worth noting. Their last point on this slide is it leads me on to the challenges. So actually you can see here that the need to focus on the workflows to get this right is key. If you automate a rubbish process, then you'll have an automated rubbish process. Now that sounds really obvious, but I've seen hospitals saying, well, we won't worry about that. And I said, if you don't address the workflow issues before you automate, you will then get system automated workflow issues, which is something that you have to be aware of. And I think barcode scanning in, whether it's meds administration, whether it's in theatre for products, implantations, it's not an easy walk. It is a bit like climbing a very large mountain. You're going to meet challenges along the way. And I think when it comes to barcode meds administration scanning, you've got to consider the space, the physical space the staff have got. What is it you're trying to scan? Not all manufacturers' labels scan perfectly well, which leads me on to the readability, because actually if staff members get error rates, they just won't use it. People management and business change really needs a team of people to support you. The end user has got to see the benefit of doing this, because if they don't, I'm sure you know, nurses tend to make the best workarounds going. And I know our pharmacy colleagues despair at us, but I'm afraid we do to get the job done. And then the technology, the challenges with the technology is if you haven't got the master data to read to, it's okay, you know, the scanner's not magic. It's got to be able to interpret what it's reading, and the master data is that. That will support that. And then working with your system providers to get them to adopt or adapt their processes to meet the workflows that you would like is not a quick process, but one that is definitely worth getting them to do. So what I'm saying is I've talked to you about some successes and error reductions, but what I'm not going to sit here and say is this is dead easy to do, and that these results are achievable very easily. They need some dedicated time, team, resource to make sure the workflow is accurate. Otherwise, you can see system results that you wouldn't want to see. That's it from me. I think I've used far too much of your time. So thank you. And I'll just open very quickly for any questions.